All right. Looks like I'm good to go. Let's see here. Some people are still hopping on here. Some attendees are just coming on here. Good. There we go. Now it's filling up. Good. I'll get started here. My name's Evan Gajkowski. I am the LVAD and ECMO manager for Geisinger Medical Center in rural Danville, Pennsylvania. I really appreciate that David Habit. He asked me to speak on behalf this afternoon of this beautiful weekend here to give a presentation about the current state of ECMO for COVID. Disclosures, I do have consulting for acute care for Abbott mechanical circulatory support. Easily said, COVID was very confusing to me, meaning I personally had friends, family, relatives, neighbors telling me one time that they really appreciated everything, and then the next minute I was being cursed at school board meetings because I thought it was important for kids to wear masks. So it was very confusing to me that people didn't want the COVID vaccine, but then someone sent this message to me on Twitter that said, please forgive me, this may sound ignorant. I had to look up what an ECMO machine is. It possible for this machine to be bought for private use? I looked online and some medical distributors have them for sale. Now paying for one might be another story. So people were trying to get ECMO at home rather than get a COVID vaccine. So it was just very confusing to me. So one of the things that our institution did first was I got together with some of our other perfusionists and ECMO team members. And we kind of put a list together of how many ECMO machines we had. Now we're a large hospital system. We have 11 hospitals in total, 3 major hospitals that offer ECMO support, and then we're the main hub, so we're a hub spoke program. So we kind of took an inventory of how many ECMO machines we did have, and what was the maximum amount of possible patients that we could put on ECMO in the beginning, and where those patients could be housed and how many beds, and just all of our staff that could, if they weren't doing anything else, could they, how many patients could we watch on the floor for that were being utilized for ECMO. One of the other things that was really, really great was the University of Penn and UPMC, Dr. Holt Murray and the team down at UPenn, really, Dr. Bermudez, really did a good job of setting up these PA COVID criteria meetings where all these hospital systems essentially got on a Zoom call every other week, and we discussed what we were seeing, how many patients, what current inclusion exclusion criteria. And we set this out there, and we all agreed that this was the inclusion exclusion criteria for these Pennsylvania hospitals. So patients, providers couldn't shop around. Essentially, if an institution called Hershey or us, you got the same answer. You were yes or a no. It wasn't like a, oh, maybe, and shopping around type thing. So it was very good for us to all come together, all these institutions come together and agree on a specific inclusion exclusion criteria. And then we also agreed that as our capacity increased, that we could utilize other institutions and that our criteria would get tighter. One instance for this was UPMC Pittsburgh got a call of a patient that was in Altoona at a UPMC hospital there, and they were unable, they were full, they didn't have any ECMO machines at the time. and they called us and we said, sure, we would take the patient. So just a nice collaboration of care and communication with hospital institutions in Pennsylvania. So this was really nice to have everybody on the same page. Again, as the criteria tightened and we had a lot of patients on ECMO, the stringent inclusion exclusion criteria we had were patients less than 50, no advanced comorbidity, single organ injury. You can see our PF ratios and pHs there, failed proning, and we had very, very strict inclusion exclusion criteria. This was in the fall, I believe. Let me move my cursor here. So this was a fall in 21. But I put this up here because a couple of people, when we showed them this during a few of our meetings, they even said that, you know, this is very tight. This criteria is very, very tight for these patients. One of the other things that I assisted in helping with the teams from UPMC and UPenn was I just kind of put a list together and I would send an email out to the chief of perfusionists or the ECMO coordinators from these other hospitals and just kind of get a tally of how many patients were on ECMO for COVID or how many they did total and if they could share their mortality or survived and what some of the things they were seeing was different, or how they were treating anticoagulation, how they were cannulating the patients. So I just kind of ended up taking a tally of these institutions, and it was just good to share with these chief of perfusionists or ECMO coordinators, just to share ideas and share what was working and what was not working. So again, you know, to all of us, some patients were being fem cannulated because they didn't want to go up to the top of the head or be near a chance of dislodging the ET tube. And so they were doing fem. That's okay. That's a way of, you know, but I've realized, and we had to do a couple of those because of access reasons, not because of fear of going up top to the right IJ, but we realized that we didn't have, you know, adequate flow, even with drainage cannulas. We probably only got about 3.5 liters of flow with fem. So fem IJ is a really nice approach, and you can do it at the bedside. And we really got used to it. Prior to this, we would use all double lumen cannulas, Avalons, Crescent cannulas in the right IJ for all of our ECMO patients. So it was nice to go to the bedside and just put these patients on fem IJ. So our practice changed because we wanted to bring everything to the patient. And instead of going to the OR or the cath lab to cannulate these patients for veno-venous, essentially, we just wanted to take everything to the bedside. So we simplified our ECMO circuit. We simplified our cart. We cannulated specifically. We got like a little box. We put everything in there that we possibly need. In the bottom right corner, you can see a box. We put tray in there, central line kits, tie bands, a gun, a sterile bowl, gloves, gowns, PIC-V kits, short wires, ACTs, CG8s, all those things. So everything that you would possibly need, you would literally take like an Amazon box that was taped up into the patient's room. That way everything could be disposed of. And then we had an old Craftsman tool cart that I actually had at my house. We just kind of fixed it up a little bit and wheeled it into the hospital. And that's what we used for our extra cart that we would resupply and keep outside of the ICU. But we did this because we weren't sure at the time of how much for contamination. And we didn't want to, you know, take all of our stuff in there at the time and have to end up throwing it away. We also limited the staff exposure during the cannulation: perfusionist, ECMO specialist, an ICU nurse, cardiac surgery, PA, and a surgeon to do our cannulations. So really limit the amount of staff that's inside the room. This is just a look at one of our cannulations. Again, at the bottom of the bed, it actually got to the point where our surgeons would simply just be supervising the fellows of critical care or heart failure fellows that would be doing the actual cannulations for these patients. So it was really good You can see the attending, he's at the bottom of the bed right next to the ECMO circuit there. He's actually just walking through some of the PAs that were doing the cannulations and supervising by the end of it. So that was nice. Our ICUs were set up, so we could see everything outside the patient's room. This is just kind of an image of how we had everything. We had some IV pumps that were outside the room that we would wire all the IV tubings on the inside. So that was convenient, but this way we could see if anything beeped. So our ventilator controls were actually moved to the outside of the room. The ECMO and the CRT machines were in full view, and vital signs were also visible from the outside of the room. So it was just we kind of really simplified a lot of things. So this slide here shows the amount of COVID ECMO consults that we received through our call center during up until some of our last COVID ECMO patients. I would say the fall of 22 here. Yeah, probably the fall or spring of 2022 from early 2020. So in that time period, we had 218 ECMO consults. So 218 phone calls of patients or from providers that needed or that would like an ECMO consult through our call center. So we said no to 176 of those. So 81% right off the bat excluded. And if we follow our diagram down, 66% of those died, 36 were discharged to home. If we said no to them, maybe they were doing okay or medically managed, excluded, or they were doing okay with prone position. Of the 42 we said yes to, we had 30 patients, which was 71% survive ECMO, 64% survived a discharge. That included 4 lung transplantations. 2 we sent to University of Pennsylvania and 2 to the University of Florida, Gainesville, which were double lung transplantations there. Those who died on ECMO, 29% were related to fibrosis, excluded from lung transplantation, multi-organ system failure. So we didn't have any hemorrhagic bleeds or ECMO complications. One thing that we did, and this gentleman here in the center is our critical care medicine chief of pulmonology. And we had him on ECMO early on before the COVID vaccine was available. We put one of our own critical care medicine gentlemen on ECMO and couldn't get him off. And so it was very difficult, struggling time for our team that somebody that we worked alongside with was on ECMO in a very vulnerable state and very sick that we had to take care of. So it was a very difficult time for our team, but we definitely overcame that. He was with us for quite some time before we could get him to a center that would do his lung transplantation. And the University of Florida, that's him there with his University of Florida transplant team. And I think he has 5 out of 5. So he was the 5th lung transplantation for COVID. I believe in the United States is what he had told me. Another gentleman that we did, and this is just to show you here on the left-hand side, us getting him up out of bed and then him coming back in and visiting us after he was with us for quite some time on ECMO. We were able to do physical therapy with him, do all the studies and tests and exams before transferring him to the University of Penn for a lung transplantation. And he is a very comical gentleman. If you see his shirt there, it says contains recycled parts on the right-hand side, but he's an advocate for COVID vaccine and also for lung transplantation patients. And you can find him on Twitter. He's got a pretty good Twitter and TikTok. He's got a pretty good following. So this is basically what we looked like here. We would have a patient we would cannulate. So And then we would try to get them up out of bed and do physical therapy with them. With the bicable cannulation, we had no problems. We didn't lose flows or anything while we were standing them up or sliding them over into a chair. But this was a female, another one that we did a double lung transplantation on. I'm sorry, University of Penn did the double lung transplantation. So she was 42 days with us, only 19 days with Penn before she got her transplant. And this was her in May, and she's doing just great as of today. So when we looked at all of our patients that we had on ECMO specifically for COVID, this was the data that we ended up with. And so our COVID ECMO data, the oldest patient we had put on was 67. That was early on. Our youngest was 18. Our oldest survivor was 55, and the oldest survivor without transplantation was 53. So you can see where that cutoff is as far as age and where we got that and where we are consistent with that today. Average age 42, largest BMI. It was not, we did not have the largest BMI in Pennsylvania. However, that belonged to Holtz Murray and the University of Pittsburgh, who proudly takes the largest BMI of a VV COVID ECMO patient that I'm aware of in Pennsylvania. The average BMI 37.9, the shortest time somebody was on a little over a week for COVID, and the longest running time was about 75 days. But overall average, you can see almost to hit that 3-week mark. So as I talked about earlier, the physical therapy part and getting patients up out of bed, we had not really done too much of this prior to COVID. And to be honest, we did a lot in a little amount of time, meaning with training and education with our nursing staff to be comfortable to get patients up out of bed that were cannulated by cable and sit them in a chair, especially if if they were intubated or if they had been able to been trachs. But these are just some of the images that we have of getting the patients up out of bed and walking them around and getting the staff comfortable to be able to do those type of things. But it was really, really great because patients got up out of bed, they were able to work, improve mobility, decrease the ICU time. And you can see the second picture in there, some of the nurses, it would just be an ECMO specialist and a nurse. They got so good at it, it would just be 2 of them in there at a time. And they would try to get their patients up. And before the day shift, so it was like 8 o'clock in the morning and they already had their patients sitting in the chair. So they would send them to me, these pictures. So we sat down with our PT and OT providers and we said, let's make a PT and OT algorithm for our ECMO patients. So is the patient bleeding, open chest, unstable flows, and we wanted to include VA and VV, not specific to VV for ECMO patients. So yes, no. And then are they alert and oriented? Are they air hunger? A lot of them do get air hunger. We just end up turning the sweep up when we do get them up to take some steps. It just seems to help them a little bit and blows off some of their CO2 or go up on their flow a little bit, but sometimes we don't really have too much room to go into. And we'll try and sit them at the edge of the bed first, and we'll stand them, and we'll try to do march in place and then get them into the bed and walk. So, and those are just some of the parameters that we look at: their heart rates, their systolic blood pressures, respiratory rates, and if they can sustain and continue mobilization during the PT session. So this is just the kind of step-by-step that we threw together, but it really helped. And we would actually just print it off and put it on the back of the ECMO machine for the PT and OT people and the nurses, just to say, these are our step points if a patient is able to get up and participate in physical therapy. We also had these nice Craig beds that we would start to stand patients in first. And on the left-hand side, you can see there this this Craig bed. We're gonna put your hips forward a bit, okay? On the right-hand side is just a patient that he tolerated pretty good, getting up out of bed and taking some steps on ECMO. while intubated. So kind of a rare instance where we were able to keep him comfortable. But it was good. We would get every morning, we would get him up and work with him. You can see the other nurses, and I think myself probably videotaping, not doing any of the work, just letting everyone else do that. But an ECMO specialist, a respiratory therapist, a nurse, this is primarily who would be in the room, as well as an extra set of hands just to be available. And we would secure the cannulas via holding of the ECMO specialist would hold him there. See if I can fast forward his cough a little bit here. But ended up doing just fine. And yep, you can see him nodding his head there, shaking his head yes. And so just kind of getting him some steps. So he's marching in places a little uneven.
You're doing great. Try to keep your eyes open so you can see where we're going.
Making sure his eyes are open, having some steps. Everything's okay. And then, you know, just get him to slowly go down into the chair. And then kind of reposition him and everything like that. So this was a daily thing for our patients, and we would get them up into the chair. We'd try to get everybody up into the chair then. And when you have, you know, 5, 6, 7 ECMO patients on COVID at the time, it's tough, but we'd go down the line, you know, we'd have them all lined up in our ICU, and we just kind of go down the line and get them up into the chair and work as a team. You know, some patients didn't tolerate it. Some of them did. You know, we would just make sure we would push them as far as we possibly could for the day. On the right-hand side is a 26-year-old female who recovered, and on the left is she was trach G-tubed and actually got a double lung transplantation. Extubate for VV ECMO. A couple of the patients with COVID, we did extubate to high flow nasal cannula. Then there was also a couple that, excuse me, we did extubate that we had to just re-intubate again. So it was, we definitely tried if we could to try to extubate them. These are some other pictures from other institutions, not anything that I have, but we did. And then if they were obtunded or some respiratory distress or just needed their airway protected, we would end up having to reintubate. So I think we had a couple out of those 40 some that we had on ECMO, maybe a small handful that we were able to extubate, tolerate on high flow. But then you commit yourself to saying, okay, I'm going to commit myself to a longer ECMO run, and we all know those complications that are related to a longer ECMO run. So, you know, what did COVID show us that or how to take care of these patients, and how did it affect, you know, for the medical management and the strategies that, you know, the ventilation, no data to suggest that deviation from commonly performed low tidal volume, low pressure for COVID patients receiving pulmonary support. Percutaneous trach at the bedside appears to be safe and feasible for patients with COVID. We did it a couple times at the bedside. We did it a couple times in the operating room. Prone position during ECMO is feasible. We did prone a couple patients that were on VV ECMO already that didn't have any lung volume return or for secretion management. And the first time we did it, you know, it was nerve-wracking, but then once we did it a couple times, it was okay. Awake ECMO, early extubation strategy, awake is feasible, but insufficient evidence to support. Again, it's just patient to patient based. If you can be able to get that tube out, you can. PPE, we knew that it doesn't appear to be spread through the lung or the exit site there. Co-infections, rehab, cytokines, we did all that stuff, DVTs, coagulopathies, blood transfusions. We actually used bivalent Rudin for all of our ECMO patients. We did not use heparin, but we started bivalent Rudin years and years ago. So it was just a quick transition to that. Some things that were published during this time were, I got you, Sherry. I'll speed it up here. So some things that were published during that time were Protect Dual cannulas. You know, they're a very expensive cannula. They're a very nice cannula. They're very single site, no recirculation. It's great. Is it a game changer? I think time will tell if we continue to use it. And for patients with ARDS, we put out through ELSO guidelines, myself and Guillermo Herrera, Lori Hatton, and some of the ELSO team, we put out some guidelines for ECMO and the circuits, and we talked about COVID in that publication. You know, and ECMO and COVID, some people were blaming the ECMO instead of COVID, but again, you got to pick the right patient at the right time. So this was just another publication that came out that talked about the analysis, a cohort of the patients that were placed on ECMO and when and how, and some a little bit more data, and not to blame ECMO itself, or don't blame the tool. And then this is nice. If you go onto the ELSO website, you can go into the COVID-19 data and look at hospitalized patients, the days on ECMO, the discharge, and some of the publications that are related to it on the right-hand side there. So overall, what we learned was VV ECMO may be utilized in patients with COVID for severe ARDS and expected outcomes comparable to patients supported with VV pre-pandemic. So there is a use for it. VA may be utilized, but experience is limited. We didn't put anybody on VA ECMO that had COVID. If they had cardiovascular collapse, usually that involved a multi-organ failure. Mobile ECMO is feasible and safe for patients with COVID. We transported a ton of patients. Organized ECMO centers of geographical regions to coordinate patients' referrals were feasible. And, we unified everybody at the same geographical region. Contraindications should be more stringent with when ECMO capabilities diminished. Data submission to facilitate research was essential. Increased anticoagulation targets. We used bivalirudin, and we increased our anticoagulation PTT goals for this time, and longer ECMO runs to recovery. So if no lung recovery and still single organ injury, we would give patients 6 weeks. And then if they didn't, at 6 weeks, if they didn't recover, we would talk about transplantation. If they could qualify for it. Let's see here. So that's what I got. I'm going to go and take some questions now. So from the anonymous attendee, from your experience with COVID, are you an advocate for placing COVID patients on ECMO early, or give them mechanical ventilation a chance first? Prone them first, and give them an opportunity to fail that before going. We are quicker to pull the trigger if we do see a PF ratio level off or decrease. So if we feel like that they're going to fail that, then we'll just go right ahead. We got so used to being like yes, no's and knowing which way patients would go. So I think in answer, I'm a huge advocate for placing the patients on early. Late in the game, it was bad. If we waited even though 7 days, if positive pressure, even if they were on like BiPAP, it was bad. So earlier the better, because I feel like, especially in COVID patients, we had a lot of fibrosis and barotrauma and stuff. So absolutely, earlier the better, but let them fail prone first. Dave, thanks so much. If such a pandemic occurred again, relied on ECMO support, would you do anything different? I'd pull that paper out that we had for inclusion exclusion criteria. And that's one of the things that I think was great, because we would just, mirror the image of that. And the fact that we already did it and lived through it, I think some things I think I would change was, towards the end, we really had it fine-tuned and knew what we were doing. So I don't think I would change anything, and you kind of live and learn with those things. But I think getting out in front of it was important, and having this inclusion exclusionary criteria was great, and communicating with other centers. What is the dosing? Muhammad, great question. What is the dosing protocol for bivalve for regular ECMO patients and for COVID? How did you guys adjust the dose and to bleeding scenario? For bleeding scenario, we would literally turn bivalve off. We just stop. And for the dosing protocol, it was the same for regular non-COVID patients. So we would start a dose at 0.1 milligrams per kilo per hour for our bivalirudin dose, and shoot for a PTT of 1.5 to 2.5 times the baseline. So if the baseline was 30, we'd try to shoot anywhere from 45 to 70. COVID was a bear with coagulation, and we realized in our younger patients that were a lot healthier, they needed a higher dose of bivalirudin before we met that goal. So, with our non-COVID patients, we still start at the same dose of bivalirudin, but it just took longer to get into a goal for those patients. And then once we were in a stable area, we would just get Q12-hour PTTs, and that was adequate. It was just a little bit of bivalirudin, and once you weathered the storm after a week of ECMO, you kind of settle in. As far as bleeding, we would just stop the bivalirudin, sometimes not do anything, and just make sure we were running higher flows through our ECMO circuit. We're not scared to change a circuit out or change a oxygenator out. So, I mean, we treat the patient, not the pump, is kind of how we look at things. High rate of component and circuit changes. If we had no anticoagulation, we obviously had to change more circuits and more oxygenators. The only time that we had anything that was weird was if patients had a couple patients that had some pancreatic things going on where their liver enzymes and pancreatic numbers were just kind of all over the place. And so, I think we're pulling the data, and we'll eventually publish that to see, Dave, about the amount of complications. But again, we would look at the post-oxygenator, we'd pull a gas, and if we were flowing super high and we couldn't oxygenate the patient, and the PaO2 on the post-oxygenator side was less than 250, and we saw clot formation and clot burden, and patient's PaO2 was quite low, what can we do? Can we turn our sweep up any higher? Do we need to blow off the condensation of the ECMO circuit or the oxygenator? We use Quadrox for all of those patients. And we use the Nautilus oxygenator too as well, but I wouldn't say that the rate of complication or circuit changes was higher. But we did see a lot of clotting inside the patient differently than other disease states. We are out of time. Okay. Thank you so much, everybody. I really appreciate it. You can email me or contact me anyway. If you need to get a hold of me, please ask Dave. I'm more than happy to answer any questions. I really appreciate you asking me to speak today. So this is great.